Hello and welcome to this recording on the session of Disability and Chronic Illness, brought to you by Mental Health First Aid England on behalf of Thrive London. My name is Alex Langridge. I've been a mental health first aid instructor since 2009 and a youth mental health first aid instructor since 2012. I also sit on disability benefit appeal tribunals as a disability qualified panel member. The session has been designed with the following aims and outcomes in mind. Firstly, increasing awareness and understanding around disability and chronic illness and the impact and relationships on these on mental health. Secondly, recognising how different models of disability can impact on social attitudes and how exclusion and prejudice in society can impact on mental well-being. Thirdly, helping you to use some of the concepts and tools that you learned as a mental health first aider to effectively support disabled people and those affected by chronic illness. You may wish to pause the recording at some stages to consider some points or questions, or listen to it straight through and revisit those points if that would be useful to you. During the session, we will be looking at some definitions of health, considering these both in relation to physical and mental health, and considering how our frame of reference can affect the way that we view health, disability and chronic illness. We will also cover some stats and facts that highlight some of the key issues that people face and consider the additional stresses that they may have to deal with in their stress container. Social exclusion and public attitudes are still a big barrier for many disabled people and those living with chronic illness. So we will be considering the importance of language and the impact of prejudice and microaggressions, along with the social model of disability. The legal requirements will be covered by an overview of the Equality Act and duty to make reasonable adjustments. The action plan from Mental Health First Aid, which you will know as ALGE, is reviewed, along with some suggestions for how to use it in the context of supporting a disabled person or someone with chronic illness. There will also be some information at the end about further resources and support. Now, we do touch on some sensitive areas, so I would as always encourage you to look after yourself, take a break from the session if you need to, and make sure that you've got some support if you need that. So what do we mean when we talk about health? Well, this definition from the World Health Organization from 1948 states that we are looking at more than just the absence of illness. You may recognise or remember this definition from your mental health first aid course. It's still widely used today, having stood the test of time. It talks of health being a state of complete physical, mental and social well-being, and not just the absence of disease or infirmity. And this is a very helpful way of bringing well-being into the conversation. However, it can make it harder for someone who has chronic illness to aspire towards such a state of health. So another definition of health that I find helpful is this one, which talks about health as being a state of balance or equilibrium within you and between you and your social and physical environment. So with this definition, such a state of balance or equilibrium could be achieved even with the most severe disability or chronic illness if one's relationship with oneself and social and physical environment is sufficiently positive. However, as we shall see, there are a lot of challenges and barriers that can make it more difficult for people affected by chronic illness or disability. Now, as we know, physical and mental health are very closely related and one affects the other. However, the way that specialist medical services are organised means that there's often a narrow focus on one aspect of health. So if there is an overemphasis in one area, other areas and aspects of health can get overlooked. This is known as diagnostic overshadowing, a term that is often used to explain why people with mental ill health may receive poorer care in relation to their physical health, and it can even affect life expectancy. However, it can also be used where the emphasis is placed on someone's physical health condition, and then their mental health is disregarded or ignored. So it's something that we should be very aware of as mental health first aiders and ensure that people are considered as whole people. So there are different ways that we might categorise chronic illness and disability, and this list is not exhaustive, and there are areas of overlap. But it shows how broad and wide-reaching the terms disability and chronic illness are. So when we're talking about sensory impairment, we're talking about things like loss or impaired vision or hearing. Mobility and physical impairments might be effects of injury, maybe spinal cord injuries, loss of limbs, or other health conditions that affect joints, muscles and mobility. There are categories of neurological disorders where the brain functioning is affected, so things like epilepsy, stroke and dementia. And then there's a whole range of autoimmune conditions, which would include things like multiple sclerosis, lupus and arthritis. Some of these are fluctuating conditions or progressive conditions. There are chronic pain conditions, again, which can be very debilitating, often unseen, but things like fibromyalgia, ME, and chronic fatigue syndromes. Neurodevelopmental conditions might be things where we're thinking about the neurodiversity, so conditions like autism and ADHD. Cognitive impairment, again, we would be thinking about areas like learning disability. And then mental illness, which you'll be familiar with, covers a range of conditions like depression, bipolar disorder and schizophrenia. Long-term health conditions, we might be thinking about things like asthma and diabetes. And then other illnesses and disease might include things like cancer and hepatitis. So as we can see, there's a very, very broad range, so it's impossible to cover all of these in detail. Apologies if I've missed some out. And I think what's really important to remember as well is to remember that many people might have more than one condition or illness, and that many of these disabilities or illnesses or health conditions are not obvious. So this gives rise to the term hidden or invisible disability. And I think that's very important to remember as mental health first aiders, that when we're interacting with someone, we may not be aware of what might be going on for them in terms of their physical health. Now, we know that people's physical health can have a real impact on their mental health and well-being, and there's a lot of evidence supporting this. So about a third of people with long-term physical health conditions also experience poor mental health. Now, the most common mental health condition experienced by this group of people is depression and anxiety. Poor physical health can also impact on mental health in a number of ways. For example, making it harder to be physically active, which we know is very helpful for reducing depression and anxiety, or increasing socio-economic risk factors, such as being out of work, experiencing social isolation, or financial hardship. There's also a lot of research that shows us that having poor mental health can impact significantly on someone's physical health, most notably in the effect that it can have on outcomes and treatment. And we can see here increased costs to the NHS of at least 10 billion a year, and that's quite an old figure as well. So someone with anxiety, for instance, may find it harder to attend appointments, particularly if having to travel to new places and meet new people. It could also be harder to engage in treatment for someone with depression, who may not have the motivation to look after their physical health and follow a treatment plan, maybe forgetting to take medication or cancelling appointments because he just can't face getting out of the house. So here we can see the significant overlap between long-term physical health conditions and mental ill health, and this is clearly seen in the central purple section. So the lighter purple circle on the left represents the 30% of the population of England living with a long-term health condition. And 30% of these people fall into that overlap with mental ill health. Mental ill health on the right in the dark purple is shown as 20% of the population, or 1 in 5. And of this group, there is an even higher overlap of physical and mental ill health, with 46% having both long-term physical ill health as well as mental ill health. So these figures really just highlight the need to treat physical and mental health together in a more holistic way, considering the person as a whole individual rather than just a diagnosis. Treating people as individuals is central to a very important concept that we teach in mental health first aid, and this is called the frame of reference. So this comes from a model devised by Jackie and Aaron Schiff, which considers how we all have a unique perspective or window on the world, which influences the way we view things. In mental health first aid, we consider how this influences our attitudes towards mental health and how this affects the way that we support people. When we're thinking about chronic illness and disability, we also need to be aware of our frame of reference in relation to chronic illness and disability, as this can affect how we interact with people and the judgments we might make about them. For example, someone who has always been fit and well and looked after their physical health through diet and exercise may find it harder to be empathic towards someone in poor physical health who eats a less healthy diet or has a sedentary lifestyle. However, it's important that we remember that there are many, many complex social and economic factors that can be involved in this, often linked to inequalities in society. And it's important as mental health first aiders for us to be aware of this and aware of our frame of reference so that we can stay in that non-judgmental space and make our communication with the widest possible range of people more non-judgmental and effective. It's also worth noting that disability and chronic illness show up as possible influences in someone's frame of reference, meaning that someone who has experience of these, either themselves or as a carer, may well have a very different perspective or understanding of the frame of reference to someone who does not have that experience. So here we're going to just talk about some stats and facts about disability, which will be helpful in our discussions as we go on. So this first one, we can see on the number of disabled people in the UK that disability is something that we are very likely to come across in our role as mental health first aiders. So there are 14.6 million disabled people in the UK, according to the Family Resources Survey of 2020-21. This also found that 9% of children are disabled, which we might equate to around 3 in an average class size of over 30 pupils. There is also often a misunderstanding around disability and a perception that most disabled people are born disabled. And this is incorrect. So research from the Institute for Public Policy shows that only 17% of disabled people were born with their disabilities. The vast majority of disabilities are acquired during people's lifetimes, and there is an increase in disability, perhaps not surprisingly, as people get older. The financial costs of disability are a real concern for people and can have a significant impact on people's mental health. A report from Scope found that families of disabled children faced on average extra costs of £581 a month, and for almost a quarter of them, the extra costs amounted to over £1,000 a month. Additional costs may include buying equipment, paying for services, specialist diets, additional energy costs, medication. And this can place stresses on families, particularly where they may be already struggling to access benefits or find it harder in work because of caring responsibilities. The current cost of living crisis is of particular concern, as it's impacting disproportionately on disabled people and people with chronic illnesses, who often have higher energy bills and transport costs. Sadly, there is still a stigma attached to disability. And research in 2018 by Scope found that a shocking 87% of parents of disabled children up to the age of 5 have felt judged by members of the public when they go out with their disabled child. So this rather sad figure shows that we still have a long way to go with regards to public attitudes around disability. Now, we know that disabled people are more likely than non-disabled people to experience poor mental health. And this is particularly marked in people with a learning disability, where mental health is often overlooked and signs or behaviours may be wrongly attributed to the learning disability rather than to the mental health of the individual. Public Health England report that children and adolescents with a learning disability in Britain are more likely to have diagnosable mental health conditions than those without a learning disability. One report found this to be 4.5 times as likely. Public Health England figures state that over 1 in 3 children and adolescents with a learning disability in Britain have a diagnosable psychiatric disorder, but of course not all of them will have been diagnosed. Mental Health First Aid Australia has developed training specifically around what they term intellectual disability, and they've produced some helpful guidelines which I've included in the resource section at the end of this presentation that helps identify signs that might look differently in people with learning disabilities and how to have conversations and use your ALGE. There are also noticeable disparities in work and education. So the Labour Force survey in 2021 found that although there are 4.7 million disabled people in work, the employment rate of disabled people is only 53% compared to 82% of non-disabled people. An earlier survey found that disabled people are around 3 times as likely not to hold any qualifications compared to non-disabled people, and around half as likely to hold a degree level qualification, suggesting that there are still significant barriers existing when it comes to accessing education and gaining qualifications. And then this can have a significant impact on people's life opportunities going forwards. So some of those stats, particularly the ones around stigma and disparities in opportunity, can go some way to explaining the huge overlap that we saw previously between long-term physical health conditions and poor mental health. And this graph from the ONS, the Office for National Statistics, illustrates a comparison of some of the indicators of mental well-being between disabled and non-disabled people. Here we can clearly see that disabled people score significantly lower on 3 important measures of well-being: happiness, feeling worthwhile, and life satisfaction, whilst scoring significantly higher on the anxiety scale. Now, this was found to be so for both men and women, and the more significantly a person was limited by their disability, the lower the level of well-being reported, which will probably come as no surprise. The same survey also looked at changes in well-being across different ages, and this chart shows the differences in anxiety levels between disabled and non-disabled people across a range of age groups. And it shows us that average anxiety levels remain elevated for disabled people throughout. However, there is a reduction both in the average anxiety levels with age and the disparity in average anxiety levels when compared to non-disabled people. So in other words, younger disabled people are disproportionately more anxious, I think. And the same chart from this chart from the same survey considers another important well-being risk factor: loneliness. We can see clearly here the disparity between disabled and non-disabled people. But again, the average levels of loneliness decrease with age for both, but most markedly for disabled people. So the disparity between disabled and non-disabled people in terms of the proportion of people who said that they felt lonely often or always decreased from 27.4 percentage points in the 16 to 24 years age group to 2.7 percentage points in the 65 years and over age group. Loneliness is known to have a significant impact on both mental and physical health and can reduce life expectancy. Loneliness was the theme for this year's Mental Health Awareness Week by the Mental Health Foundation. So by working to reduce loneliness for disabled people, especially I think with younger disabled people, we can therefore hope to have a significant impact on improving their mental health and well-being. It's notable that these figures are pre-pandemic. So whilst social distancing had an impact on everyone, it had a disproportionate impact on disabled people and those who were clinically vulnerable, with many people having to shield for extended periods of time and being cut off from their vital support. So this undeniably had a disproportionate effect and impact on the mental health and well-being of vulnerable people, people living with chronic illness and disabled people. So let's come back to a concept that should be familiar to you from your mental health first aid course, which is the stress container. So an important part of this is acknowledging that people have different sizes of stress containers. and that someone with a smaller stress container may be more vulnerable to stress in that their stress container will fill up more quickly. Now, some disabilities, health conditions or neurodiversity may impact on the size of someone's stress container. For example, someone on the autistic spectrum may have an increased sensitivity to environmental stressors, such as noise or temperature. Now, identifying and using helpful coping strategies is, of course, one way of reducing stress. However, where possible, adapting environments to be less stressful and more accommodating to an individual would also be recommended as a type of adjustment that can reduce that stress. So it takes some of the emphasis off the individual, but obviously we have to look at both. So let's have a consideration in a little bit more detail about some of the additional stresses that may be faced by disabled people or people with chronic illness. Now, it's important to remember here, though, that stress is a very individual thing, and that what is perceived as stress by one person may be experienced very differently by another. Now, if someone is experiencing physical stress from pain or exhaustion, this can have a significant impact on their capacity to manage other stresses. And again, of course, this varies between individuals as people have different pain thresholds and tolerances. But pain can be really debilitating, especially if it's constant and overwhelming. If energy levels are affected, for example, in conditions like chronic fatigue syndrome or following treatments like chemotherapy, it becomes more difficult to deal with everyday things that need attending to, so they can build up and become very stressful for people as well. The uncertainty and worry that can be experienced, especially following a newly diagnosed condition or being diagnosed with a progressive illness, can be immense and very stressful for people. So any change is stressful, but changes in health, particularly where there is uncertainty, are extremely so. There can be worries about the future, what the prognosis is, how other family members will cope or react, amongst many, many other things. There's also stress from attending medical appointments and managing medication. So sometimes people might have to wait a long time on waiting lists or travel long distances for appointments. And this might mean having to take time off work or school and then having to catch up on missed work. And this is really problematic, especially for young people if they're studying for exams, that stress of having missed work and having to catch up. Also within workplaces, if adjustments are not made for allowances for that, that can become problematic and impact on people's demands in the workplace and increase stress. As we saw in the previous stats, there are increased financial costs for disabled people, and this can also be true for people living with chronic illness. So people may have to take time out of work or reduce their working hours, in addition to costs like prescriptions, buying equipment, travel and parking for appointments, additional heating or energy costs. So although there are benefits that people can apply for to help with these costs, they may not meet those costs sufficiently. But even if they do, navigating the benefits system can be very stressful in itself, filling in forms and having to attend assessments. And not everyone is successful in being awarded benefits when they do apply. And the appeals process can take a long time and also be extremely stressful. Now, sadly, some people also worry about the increased cost and care that they require and feel like this places a burden on people that they live with or people who provide that care. And that sense of feeling like that, again, can be very, very stressful for people. The way that society is structured and the barriers that exclude people from aspects of society can create significant stresses. So, for example, although we have equality laws that mean public transports that should be accessible for disabled people, there are still significant barriers that disabled people face when trying to use public transport, for instance, to get around London. There are very often equipment's not in the right place or it's broken. And, imagine trying to deal with that on a daily basis. It requires quite a lot of planning, which can add to extra stress. Also, there's a lack of visibility and representation in a society which you might say is steeped in ableist language and imagery. And this can make people feel different, and negative attitudes towards disabled people, including prejudice and stigma, can lead to discrimination or bullying, which again are extremely damaging, stressful experiences to go through, and and can have a real impact on people's mental health. So that's some of the ones that I came up with. In our work groups, we came up with a whole range of other things as well. And I think it's, again, important to remember from individual perspectives, what are the things that are causing stress in someone's life, and then looking for ways of removing that stress or encouraging those helpful coping strategies to help someone manage and deal with it. So I'm going to move on a little bit and just think a little bit more about the attitudes in society, because these can really have such a significant impact. So we could identify prejudice as being negative judgments about someone based on a preconceived idea or assumption. Stigma we might define as being a mark of disapproval applied to a group of people who share particular characteristics such as a disability or mental illness. And then discrimination is less favourable treatment on the basis of those characteristics. There are also microaggressions. Now, this term is often used in the context of talking about race and the daily or commonplace slights or snubs that people are subjected to, whether intentionally or not, because of their race. Now, these are not small things, as the name might suggest, as their cumulative effect can be massive and very, very damaging. But microaggressions can be directed at any marginalised group of people, and disabled people report experiencing them on a regular basis. One woman, Louise Halling, shown in this picture, made a short film about her experiences to highlight the issue. This film is available to watch on the BBC website and is well worth a view. You'll find the link to the film in the resources section at the end of this presentation. But it includes people making comments like this one when she's out on her mobility scooter. Oh, I could do with one of those. And she makes the point that actually she'd swap it for legs that she's able to walk on. So moving on then to the importance of language. And this is so important when we're talking about disability, because it can have a significant impact on how people are perceived in society and how individuals perceive themselves. So in our live session, we divided into 4 groups to consider these terms which might be used in relation to disability. And we discussed which ones we would definitely not use, which ones we might use, any we felt comfortable with, or any alternatives which we would prefer. Now, the idea here was not to be too prescriptive, but to open a discussion to illustrate the impact that language can have and identify ways to make our language more inclusive. So there were some terms which we generally agreed that we would not use. So talking about someone suffering from a condition can make an assumption and place a negative emphasis which may not fit the person's experience. It's also usually better to place the person first and then the condition, maybe saying something like someone with a diagnosis of or living with, rather than using the condition as a label. However, some people, for instance, with diabetes are quite happy to describe themselves as a diabetic. So there were suggestions that asking someone or using the language that they prefer might be a good option. In group 2, the term wheelchair bound we agreed that we wouldn't use, as it's inaccurate and suggests that people are unable to leave their wheelchairs. The use of the word issues can also be seen as being a bit negative, so maybe someone with mobility or access requirements would be a better term to use. Wheelchair user is a little shorter to say than saying someone who uses a wheelchair, but again, it's a good idea to check on language preferences. In group 3, we had an interesting discussion, particularly around the term special needs, because whilst it's still used in schools referring to special educational needs, it's a term that's often been used as a derogatory term and can come across as condescending as well. So a lot of people felt that that would be one that we would avoid. We talked about the requirements and needs and thought that maybe requirements could be used as an alternative to needs when talking about communication or access. It places more emphasis on the adaptations required rather than the individual needs. However, again, we have to be sensitive to individual preference here. And in the final group, group 4, we were talking around terms around disabled people, and we agreed that we would not talk about disabled people using a term like the disabled, because it sounds derogatory, it lumps people together and creates an othering effect. However, the term disabled people is actually favoured by the disability rights movement over the term people with disabilities, as it fits with the social model of disability, which places the emphasis on the disabling effects caused by society. So this sees the individual as being disabled by society rather than their impairment. And the impairment is seen as the difference in someone's body or senses. So in a society where we are accepting of differences and in an enabling society, the disability would not exist or would rather be reduced. And therefore it makes less sense from this perspective to talk about people with disabilities as if it were fixed. So to explore that a little bit more, I'm going to look at a couple of models which help us to understand where this language comes from. So first I'm going to look at the medical model of disability, which is a way of looking at disability which sees the impairment, condition or difference in a person to be the source of the disability. Okay. So the problem then becomes the disabled person, because they can't walk, get out of the house, see, hear, someone needs help, they need a cure, they need carers. So it's a sort of a helping model which really disables a person by being able to empower themselves. The emphasis here is placed on the medical profession to provide a cure or care for the person, and then for the person to live with the disability that they experience. So this is not seen as a very empowering model of disability, and it was challenged by the disability rights movement, which really started from the 1960s, who said that actually the problem is not the person with the impairment, the problem is with society and the lack of accessibility. So the disability rights movement challenged the medical model and came up with a social model of disability. And this redirects the emphasis towards the government, society and all of us as individuals to create a more inclusive society, removing the barriers and negative attitudes that disable a person. So in this context, disability is seen as a social construct, the problem being the disabling world with inaccessible transport, badly designed buildings, a lack of job opportunities, too few sign language interpreters and isolated families. So this gives us maybe a more positive framework with which to challenge those inequalities within society and make society a more inclusive and enabling place for disabled people. Now, what strikes me as always quite shocking is to understand or realise that until 1995, there was no legal protection for disabled people against discrimination. The Disability Discrimination Act of 1995 was the first time that disabled people were given this legal protection. And then the Equality Act 2010 replaced the Disability Discrimination Act. And the Equality Act applies to disability where someone has a physical or mental impairment that is long-term. Now, long-term here refers to longer than 12 months or likely to be. The other aspect is that the impairment has a substantial negative effect on someone's ability to carry out their day-to-day activities. And here the term substantial means anything more than trivial. So it could mean, for instance, taking much longer to get dressed than it normally would, or having problems using public transport. Fluctuating conditions like arthritis are also covered by the Equality Act. And there are special rules that apply here. Progressive conditions that get worse over time can also be covered by the Equality Act. However, you automatically meet the disability definition under the Equality Act from the day that you're diagnosed with HIV infection, cancer or multiple sclerosis. There are different types of discrimination, such as indirect and direct discrimination, and these are prohibited by the Equality Act. And a failure to make reasonable adjustments for a disabled person is also a breach of the law. So reasonable adjustments should be provided to remove the disadvantage that disabled people face because of their impairment. Reasonable adjustments are designed to create a more equal field and are required in areas such as employment, education, housing, goods and services like shops, banks, hospitals, leisure centres, and in private clubs like Scouts or Guides. In schools, many of the reasonable adjustments may already be covered by provisions put in place if a pupil has SEND support or an educational healthcare plan. However, there are pupils who do not have these who may also require reasonable adjustments, so it's important that these are considered. Now, when deciding what is reasonable, consideration is given to the cost relative to the size and resources of an organisation, how much disruption it would cause, and whether the adjustments would be effective. The effect on other pupils is also something to consider. So, for example, it would not be reasonable in the case of a student who is adversely affected by the cold for the school to have to turn up the heating to such a level that it had a negative effect on other pupils. It would, however, be reasonable to move that pupil to a warmer spot in the classroom, maybe provide some extra heating, allow them to stay indoors in cold weather, and permit the wearing of additional layers of clothing. Health and safety is also another area which should not be compromised by reasonable adjustments. Some areas of reasonable adjustments in schools might allow extra time to complete work or providing auxiliary aids, note takers, adaptations to make buildings more accessible, and additional support for assistance from staff. A good source of further information about making reasonable adjustments is the Equalities and Human Rights Commission, which the details are included in the resources at the end of the presentation. So let's look now at ALGE, which is our action plan for supporting people when we've got concerns about their mental health. So this is a bit of a recap, but looking at it from the perspective of the things that we might need to consider when supporting someone who has a chronic illness or is disabled. So using our A in ALGE, it's important that we consider our approach carefully with regards to time and place. So how we open the conversation, and it's always going to be better to focus on the person as an individual, asking them questions about how they are in themselves rather than focusing on the illness and disability. Although, of course, if that is causing difficulty or is part of the problem for them, be open to discussion around it, but avoid giving advice. Now, assessing risk is an important part of being a mental health first aider. And here it's worth noting that chronic illness and disability are significant risk factors for poor mental health, and particularly with crises associated with this, such as suicide, self-harm, panic attacks. There may also be an increased risk of psychosis, especially in people with a learning disability. So it's therefore important to stay alert to this and to warning signs in relation to suicidal thoughts and respond appropriately. Remember that asking clearly and directly about suicidal thoughts or plans does not make it more likely that someone will act on these. Instead, it gives people an opportunity to talk about how they are feeling. And then the assessment of risk can be carried out and steps taken to keep that person safe. So using clear and unambiguous language is the best approach, adapting this if necessary to the level of an individual's understanding. There is some guidance around this for people with a learning disability from Mental Health First Aid Australia, which is included in the resources at the end of this presentation. Assisting in a crisis may also mean staying with the person until help arrives or ensuring that they get urgent medical attention. It's important also to pass on information appropriately with consideration of confidentiality balanced against the need for safeguarding of young people or vulnerable adults, remembering that confidentiality does not imply where there's a risk to individual from suicide or self-harm. If there's an immediate risk to life and emergency services or the police have to be involved, reassure the person that they are not in trouble, but you need to keep them safe. So hopefully that helps you just reflect a little bit on the A part of ALGE, so our approach, our assess and assist in any crisis. So the L, which is listening and communicating non-judgmentally, is a really important part of ALGE. It's really important to here, as I've said before, to be aware of your own frame of reference in relation to disability and chronic illness, as well as considering the frame of reference of the individual with experience of this, because your own frame of reference will have a profound effect on how you communicate with and support someone, and their experience of chronic illness or disability will have an effect on the way that they experience or perceive the world. Always try to remain in a non-judgmental frame of mind, remembering and practicing the other key components of non-judgmental listening, acceptance and empathy. G, which is giving support and information, and we would consider what sort of support and information is relevant, but it's important that we avoid making assumptions here about what kind of support someone would like. So always ask someone what they think might help, and if they're not sure, offer some suggestions, but allow the person to make a choice about what they would prefer. In terms of information, if you don't immediately have relevant information to hand, you can always offer to find out for someone, or you can work together to help them find the information themselves, which is always a really empowering thing to do. Our first E is around encouraging appropriate professional support. Now, there can be barriers accessing appropriate professional support for disabled people and people living with chronic illness. So there may be a lack of therapists, for instance, who are trained in signing for deaf people, or assumptions can sometimes be made about a person's ability to engage in talking therapies if they have a learning disability. Encouraging someone to talk to their medical team or GP can be really helpful though, as there may be specialist support service that they can access. For example, there are organisations who can provide ongoing support for anyone who's received a cancer diagnosis. So exploring those options is a really helpful thing to do. And then our final E, which is about encouraging other supports, and this is just to remind you that many voluntary or sector organisations exist to support disability and chronic illness, and these can provide a route to getting individual help or connecting with other people through forums or peer support. And looking for ways that people can become more involved in the community might be helpful if someone's become socially isolated because of disability or chronic illness. However, it's important that we don't make assumptions again here, and looking for ways that people can become more involved. There may be some barriers. So, for example, someone feeling worried about being accepted, a lack of accessibility or prohibitive costs. So explore options and be led by what someone thinks might be helpful for them in terms of support, rather than imposing what you think might help. If barriers are identified and the person would like help to overcome these, offer support and explore ways to overcome these barriers. For example, finding someone who's able to accompany the person, or contacting an organisation in advance to check about accessibility. Support from family and friends is also very important, and sometimes people feel that they already ask too much of those close to them. So here we could help by reassuring them that it's okay to reach out and talk about how they are feeling, and that people would really want to help and support them. So remember, lastly, that ALGE can also be used to support friends and family, since people with caring responsibilities are at higher risk of developing poor mental health themselves. So consider making an approach to someone who has a role as a carer if you've noticed changes in them, and check in on how they are using ALGE. Taking time to listen non-judgmentally and encourage appropriate support from GP, carers or carers organisations. Doing so can really benefit someone who's unwell or disabled, since if those supporting them feel that they have support themselves, they are better able to be there for them. So here we have a case study which we used after a consideration of ALGE to think about how we might apply ALGE to explore what is happening for Nadia and how to offer appropriate support and assistance. So you may wish here to pause the video, read the case study and consider your response. One of the most important parts that we discussed following this case study was the importance of the approach and making a connection with Nadia, so that she feels safe to open up and share sufficiently so that we could make an assessment about any possible risks. Having a chat with her while she was sitting out of a PE lesson or on her own at break may be one way of doing this, or making some time during a meeting to explore what is going on. Stay alert for warning signs of a crisis, for example, suicidal thoughts or self-harm, and follow the guidance from your mental health first aid training should these become apparent. staying with Nadia if there is immediate risk, and ensuring urgent attention and a safeguarding referral. If there's no immediate risk apparent, continue with the other parts of ALGE, using the listening and communicating non-judgmentally to open up the conversation to explore what is happening. This will help you to be more able to offer appropriate support and information. Be careful not to make assumptions by putting everything down to her physical health, as there may be other things happening in her life that could be overlooked. Consider what professional support for her mental health may be available. For example, seeing a school counsellor or support from medical professions already involved with her healthcare. And begin by asking if this is something that she may wish to explore. If she declines seeking support, there may be reasons for this, and by continuing to listen and showing respect, you may be able to encourage her to explore this and consider accessing support in the future. Encouraging other support is also really important, especially as she's becoming more withdrawn and looking tired. So having a discussion about engaging in groups, perhaps where there's less requirement to be physically active if this is difficult for her, along with consideration of self-care activities and getting support from family and friends. This can be really helpful and can provide Nadia with the recognition that she has some ways of helping herself and can then see the benefit of seeking support from those close to her. Remember that if you begin with a sensitive approach and non-judgmental listening that establishes a good relationship, the rest of ALGE will be better received, and other steps can also be revisited if necessary. So here I've included some of the references and resources that I used to put this session together. Some of them are specific to particular types of disability or illness, but they also have information that can be useful in a variety of situations or conditions. You may wish to explore these resources in more detail, but don't forget that there are also many useful resources related to mental health support in the manuals that you will have received when you did your mental health training. There are a couple of short film clips that are very useful to watch. So the first is the short film clip by Louise Halling on the BBC website, which highlights the impact of microaggressions on disabled people. And the second is a cartoon that illustrates the social model in a very light-hearted but thought-provoking way. So here's a summary of the content that we've covered in the session, starting with some definitions of health and some stats and facts about disability, and considering the importance of the frame of reference and the increased stresses that disabled people and people with chronic illness face. Some of those increased stresses arise from negative attitudes and exclusions in society, and we covered the impact of this along with a consideration of language and microaggressions. Looking at disability from the perspective of the social model gives us an alternative view which places a requirement for society to change to become more inclusive. The legal requirements were touched on with a brief look at the Equality Act and reasonable adjustments. We then reviewed ALGE, the action plan we use in mental health first aid, and highlighted areas that may be important to consider when supporting a disabled person or someone with chronic illness with their mental health. Finally, I highlighted some further resources which you may wish to explore and some film clips which I hope you'll watch. So thank you for giving your time to watch this presentation. I hope you found it useful and it will help you to use your mental health first aid skills even more effectively. If you would like more information, here is my contact email. Alternatively, you can contact Mental Health First Aid England. Thank you again for listening. Goodbye and enjoy the rest of your day.